Neurogenetics, Neurocutaneous Disorders, and Muscular Dystrophies, Module 4, Lecture 6 in the Genetic Series. Neurofibromatosis is a common disorder occurring in approximately 1 in 3,000 individuals. It's inherited in an autosomal dominant fashion. In order to make the diagnosis, you need two of the following: a family history of neurofibromatosis, or NF1, 6 or more Café Lait spots, 2 or more Neurofibromas, Lisch Nodule, Optic Glioma, Angiofibromas, or axillary and/or inguinal freckling. So you need 2 of these features. So Café Lait spots, you need greater than 6 postpubertal, and they have to be 1.5 centimeters by 1.5, prepubertal 0.5 by 0.5. They're first noticed in infancy. So here we have 1, 2, 3, 4, 5, 6. So once I get to about 10, I really stop counting and measuring. Most patients with NF have an excess of 20. Freckling in non-sun exposed areas, such as under the arm or in the inguinal area, 85% of patients will exhibit this feature by age 10. So if I see a newborn, they may not have it. But if I'm examining an adult, this is a feature I should be seeing. Neurofibromas are soft, fleshy growths, superficial or deep, and they usually start occurring during pre-adolescence. They're spindle-shaped cells with collagen and nerves. An optic glioma is the most common CNS tumor. 15% of patients have this when they're imaged. 1/3 of patients with a glioma will develop decreased visual acuity, proptosis, which is when the eyes push forward, strabismus, headaches, and nausea. These are Lisch nodules. I've never actually seen Lisch nodules that look like this. Most of the time you need an ophthalmologist to do a slit lamp exam. But Lisch nodules are iris hamartomas. They're usually seen, as I said, by slit lamp exams. And again, 25% of patients will have this at age 5, 50% by 10, but 95% will have this by age 20. So if you're seeing an adult for possible NF, this is, if you don't see Lisch nodules, it may not be neurofibromatosis. Orthopedic signs, fortunately these are rare, but an osseous defect of the fibula can be one of the first signs of neurofibromatosis during infancy. Hypertension is also very common in NF1 patients. It can develop at any age. And most cases are essential. And essential means we have no idea, it just happens. Other causes include renal artery stenosis and coarctation of the aorta. The next neurologic neurocutaneous disorder I'd like to discuss is tubular sclerosis. Tubular sclerosis occurs in about 1 in 6,000 individuals. Café Lait spots, or CALS, are seen in some patients. They also have adenum sebaceum. They look a little bit like acne on the face. Facial angiofibromas. Fibromas under the nails are periungual fibromas. This is a Chagrin patch, so sometimes we have to get a Woods lamp to look for these hypopigmented lesions. They can also have retinal hamartomas, cortical tubers, subependymal astrocytomas, cardiac, and renal. Cardiac rhabdomyomas are a prenatal sign of possible tuberous sclerosis. If it doesn't, they usually resolve shortly after birth unless they're so severe. And again, here's this Ashley spot. Duchenne's muscular dystrophy is a neurologic disorder. It occurs in about 1 in 5,000 males. It's X-linked recessive, and it only occurs in males, so this does not occur in females. Features include progressive muscle weakness, calf hypertrophy, and toe walking. Patients are usually wheelchair-bound by age 16, and death in the late teens or early 20s, secondary to heart failure or dilated cardiomyopathy. So the muscle is weak and it's being replaced by fat all over the body, and the most important muscle in our body is the heart. So in physical exam, there can be muscle weakness on the upper and lower extremities, proximal greater than distal, and calf hypertrophy. And we're also going to look at the Gower sign. And the Gower sign is the way that this child has to stand up, and notice him trying to like walk up his legs. So he can't just, this is, a 3-year-old, he can't just get up, he has to kind of walk up his legs. So we'll watch this one more time. Instead of him just standing, he has to kind of stand and then watch him kind of walk up his legs, and he doesn't even lose his stickers. Very good. So Duchenne's muscular dystrophy, there's no protein dystrophin made. 90% of patients have a deletion. This is a very large gene. It's a deletion of the gene. 10% have a point mutation within the gene that results in early stop codons, so no protein is made. There's also a milder change in this gene that makes some dystrophin but not enough, and this is known as Becker's muscular dystrophy. So Becker's is you have abnormal dystrophin. It's altered, but some is produced. It has a milder phenotype than Duchenne's, a little later of onset. But similar to Duchenne's, they die eventually of dilated cardiomyopathy. So management, physical therapy, steroids have been shown to improve muscle use for longer periods of time. Cardiac medications to improve the cardiac function. And there's a lot of research looking for future therapies, including exon skipping, as well as CRISPR. Myotonic dystrophy. This is inherited and autosomal dominant. It occurs in 1 in 500 individuals. Most of the time it occurs during adulthood. It's a triple repeat disorder with an increased number of CTG repeats. Normal individuals have between 5 and 37. And the more repeats, the earlier the onset. The adult onset is around 100 repeats. So it affects skeletal, cardiac, and smooth muscle. And muscle weakness begins in the face and presents and spreads to the distal limbs. And here we have a brother and sister. Another thing you can see is frontal balding. He's only 19 years old, and he's already showing frontal balding. You can see the expressionless face. Open mouth, inability to grip or release a grip. So sometimes they have a hard time letting go of a door handle, or they don't let go of a handshake. Now, the late onset, over 50 CTG repeats. Early symptoms include cataracts and slight muscle weakness. Classic myotonia between 100 and 1,000 repeats. Childhood, learning disabilities, long face. As I was showing you, those two children, one had 800 repeats and another had 900. And there's actually a congenital form where the baby has severe hypertonia, respiratory problems, club feet, between 1,000 and 5,000 CTG repeats. I would not think of this as a diagnosis congenital unless it was a family history of myotonic dystrophy. Sometimes they don't know the family history, but on exam, the mother would have some mild delays, a long, elongated face, and things like that. So as I said, here is actually a family history. Here's the grandmother with a little bit of an expressionless face. Here's her daughter with a definite expressionless face. And here's the young child. And again, when it gets over 500, there's starting to be cognitive delays and whatnot. The number of CTG repeats increase during oogenesis. So it's during spermatogenesis. If a male has this, there's a 50% chance he will pass it on. But it's usually the same number of repeats. So if he had 48 repeats, his child would have 48 repeats. Whereas in oogenesis, it could go 48 to like 500. So a 40-year-old male has a lesion on his abdomen removed. Pathology indicates it to be a neurofibroma. On exam, the patient has 10 Café Lait spots and axillary freckling. What is the most likely diagnosis? Tubular sclerosis, Neurogenic syndrome, neurofibromatosis, normal variant, or Klinefelter's. And the correct answer is neurofibromatosis. This concludes this module.